Hello, welcome to Cardia-Hearts and Sciences, the program dedicated to the understanding of the human heart. I'm Mark McDonald alongside with co-host Dr. Greg Mishkel, our Dean of Hearts and Sciences, who also happens to be the Chief Medical Director at Prairie Heart Institute,
or
the
something.
Executive Medical Director at Prairie Heart Institute, and Dr. Sachin Goel, Interventional Cardiologist. And Dr. Goel, we're going to ask you to take us through a procedure today. So we're going to get a close-up look at some of the work you do. But first, Dr. Mishkel, I'd like to ask you how we're going to be looking at structural heart today, and how that fits under the umbrella of the overall study of cardiology.
Right, so I want to be brief because I don't want to detract from the work that Sachin does. But so not only do we work on the electrical system of the heart, the plumbing system of the heart, but now we start to work on the heart itself. And so there's a field of cardiology called structural heart that works on fixing holes in the heart or fixing valves in the heart. And the procedure we're going to hear about from Dr. Goel today is really a kind of a remarkable procedure. He's actually one of the only ones in town who does this procedure. He's really pushed it forward, and that's how we fix leaky valves with a special device.
Doctor, and what we're going to look at is what's called a mitral clip. But is that to fix the mitral valve? Is that what the mitral clip is for?
That's right, Mark. Mitral clip is a small clip, as the name implies, which is made of a metal alloy that is covered with a polyester fabric. And the purpose, as Greg pointed out, is to repair a leaky mitral valve. This is a non-surgical technique which does not involve opening the chest as a heart surgeon would. Instead, it involves going up the groin vein and placing this clip on the valve to reduce the amount of leakage through the valve.
Now we're going to look at an actual procedure, but first I want to look at an animation because it'll give the audience a sense of what's actually being done in the procedure. So if we look at our first clip, we can take a look at, this is what is called the mitral regurgitation, and you're not just supposed to see that blue flow there, are you?
No, that's exactly right. The blue flow was between the left lower chamber, which is the main pumping chamber of the heart, and the left atrium, which is the upper chamber. And the blue flow was the leakage through the mitral valve. That is abnormal. Now,
what are we seeing as we go? We're taking the clip up inside the body.
So the technique involves going up the groin vein, as you saw, up through the main vein in the belly, and then poking a hole between the right upper and the left upper chamber to gain access to the left atrium, which is where the mitral valve is located, between the left atrium and the left ventricle. On the screen, we see a clip which is being advanced through a large bore catheter or a guide catheter.
The clip's closed right now.
The clip's closed, and the clip's it is able to be maneuvered and lowered down to the level of the valve, and it can be moved to the front, to the back, to the left, to the right. And as you see there, the clip is being opened. This is all being done controlled from outside the body, Mark. And the clip can be oriented perpendicular to what we call the line of coaptation in the blue blood that is leaking there. So we can orient this clip exactly in the area where the leakage occurs. And then the clip, as you see, is being lowered from the left upper to the left lower chamber, and the leaflets are being grasped. That is the word we use here. We are trying to grasp the leaflets. And we can do this till we are sure that we have the leaflets inserted in the clip to reduce the leakage to the maximum. Only after we are certain that the leakage has reduced to a significant degree, after checking with ultrasound and other methods, then we then we release the clip, as you will see in just a moment here. So the idea is to grasp the leaflets, and
it stays in place.
And it stays in place.
So you have just pinched that closed and permanently now.
That's exactly right.
And there's no more blue flow, which we saw was the regurgitation coming through.
Correct. It is placed exactly in the area of the leakage. So blood can still flow from the upper to the lower chamber on either sides of the clip, but by putting the clip in the area of the leakage, it prevents flow back up from the lower to the upper chamber.
Well, that's terrific. Now, we're going to see an actual procedure. And of course, it's not as easy to see because, of course, it's all being done with a catheter and it's all inside. But you, the doctor, the cardiologist, has to look at it through x-rays and ultrasound and all those kinds of things to see what's really going on. So let's take a look at how we get started. We get started here by lowering...
Now, there's something very important here because I want to give credit. That's Dr. Vince Zuck, who has been with us from the very beginning And he is probably Sachin doesn't want to hear this. He's the most important person in the room because believe it or not, he tells us left, right, forward, backwards.
Is that right?
And Sachin responds to his instructions. So he's putting down that scope into the gullet, and that scope's going to lay right behind the left atrium where Sachin's going to be working.
Okay, and that scope is showing you pictures of what, Dr. Goel?
That's a very good point. The scope is showing actually the pictures of the valve. It tells us where the leakage originates in the valve, where our clip is, what the orientation of the clip is in relation to the valve. And as you saw in the animation, Dr. Zuck tells us whether we need to rotate the clip counterclockwise or clockwise to orientate it properly so that we can place the clip in the right place and reduce the leakage.
Okay, now at that time the patient is sedated, has the camera down properly in the place. And the next thing is, of course, you start with the catheterization, I guess, and that's what we're going to see in the next clip. And that's there, here we go. And this is getting started, isn't it?
This is, yeah, exactly right. After Dr. Zuck has taken his preliminary pictures and the patient is under anesthesia, we obtain access in the groin vein. So this is done via venous approach. And here we're getting access in the vein. And then we put the catheter through the groin vein, go up the big vein in the belly, and enter the heart.
Let's go ahead and move forward with the next clip then, because what we'll see is you start looking then at the x-ray. Now, this looks like this fellow already has a stent or something in there already. Would that be true?
That's a great observation, Mark. This patient actually had a transcatheter aortic valve procedure, which is another one of those procedures that Greg mentioned about a year and a half ago, and then had progressive leakage through the mitral valve. So this is truly remarkable technology where we can treat patients with two valve problems without open heart surgery. One valve problem with a transcatheter valve, and the other problem is the leakage, which we're treating here with the help of a mitral clip.
You also see that this patient's had a pacemaker. So just think about all the benefits of technology that this patient has had. He's had pacemaker, he's had an artificial valve put in without surgery, and he's going to have his mitral valve leakage fixed by Dr. Goel with a little staple.
Oh, now that's an ultrasound, I assume we're looking at. That was all part of what Dr. Zuck was lowering in there, is that right?
That's actually a key part of the procedure, which is what we call transeptal puncture, which is simply getting access into the left atrium by poking a hole between the right upper and the left upper chamber through the septum, or the wall, if you will, between the upper two chambers. And this requires precise placement. We do this by a radiofrequency needle, and the location of the puncture is critical.
You can see the tenting there.
Procedure. So this is a three-dimensional picture.
They're about to poke through that little hole there.
Okay, that's what the doctor there is pointing at. Okay.
That's right.
And what does this color image tell you besides that?
So the location of the puncture is very important. Anatomically, it tells us where we are in relation to the other structures of the heart. And that is a key point in getting access and then proceeding with the remainder of the procedure.
Okay. Now the remainder of the procedure is what we're going to start to see now, because you unfurl a rather large looking white catheter here, and it looks like that's the next step.
So we have performed the puncture with the help of a radiofrequency needle, and we're putting a special wire across that septum into that left upper chamber.
So he's working with Dr. Faneri here, who is our fellow. We have every year one or two people who come and spend the entire year with us from all over the United States to learn how to do these sorts of procedures.
And what does this show us?
So this picture is, again, a three-dimensional ultrasound picture of the heart that Dr. Zuck is providing. And we can see the wire in the left atrium, the left upper chamber, right above the mitral valve.
See the mitral valve like a fish mouth opening from above? Isn't that amazing?
Yes, it is.
And that's the wire going into that chamber.
Wow. Okay, and what does changing the color do for you?
So he's trying to make the image clearer and identify the location of the pathology, the problem with the valve, which is located to the left part of the screen there. This patient had what we call prolapse, or flail, of the posterior leaflet of the valve.
You see a little pouching on the far left?
Yes.
That's the valve blowing backwards. And that's where the leakage is taking place.
Okay, and that has to be clipped shut. That's the whole purpose of this whole procedure. Then,
That's
is to
exactly
clip
right,
that
Mark.
shut, as we saw in the animation. Okay, now the next tool that we get to see come out, that's the actual clip that's going to go up. I think you tell us, Dr. Goel, but it looks to me like this is probably the device that's going to feed that up there.
That's exactly right. So this is a very sophisticated device. It has buttons and knobs, as you see there on the screen. The
Very
purpose-
sophisticated.
For a construction worker, yeah.
That's exactly right. So the purpose of these knobs and buttons are maneuverability, steerability, and as Greg pointed out earlier, being able to move the clip back and forth in the front and the back, to the left, to the right, so that we can get precise placement of the clip. So we are carefully prepping the guide catheter and the clip delivery system outside the body, and then we advance this 24 French system through the groin, up the vein, through the heart, into the left atrium, across the hole that we just made.
Mm-hmm. Okay, now that steadies you have got a lot of assistance there to help you steady that, because that's a rather large tool, isn't it?
That's correct.
Yeah, that's pretty big.
It's a pretty bulky device.
Yeah.
But ultimately, what remains inside the patient's heart is just that small clip. All this, all this material, all the device that you see, this all comes out at the end.
Mm-hmm. That'll all be retracted, and the only thing that'll stand is that tiny clip. And what keeps that clip in there?
That's a great question, Mark. So the clip has, as you saw it in the animation, it has two arms which open up. Those are the clip arms. And right above the clip arms are small arms known as gripper arms. So the leaflets are grasped between the gripper arms and the clip arms, and that's what holds the clip in place.
Okay, we're going to see that in the next clip, because what we have is it's open now, isn't it?
There
and
you
that's
go,
what
yeah.
it'll look like. Is that what it'll look like when it's actually deployed?
Correct. It will be closed a little bit. Right now it's open, but when we grasp the leaflets, the clip is closed.
Okay, we're going to get a good look at this, and that looks like a friend of ours. I think that's
Yeah.
Dr. Goswami, who's
can-
going to be on this program
I
later
can tell
on.
from those beautiful
Yeah.
eyes.
He'll be on to talk to us about something else in the same program. But he's taking a good look at the tool, and he's going to show us how it opens and closes here in just a moment.
So there we're opening the clip. The white structure that you see opening is the clip arm, and underneath the white arms is a small sort of plate, which is actually the gripper arms. And the purpose is to grasp the leaflets between those two structures on each side.
Mhm.
And there now we're inserting the clip delivery system through the large catheter
Wow.
into the body.
That's amazing. These catheters, they have to, is that about as big a catheter as you can fit into a vein? Is that about as big as you can go?
Well, you could go larger, but
Really?
this is a pretty large bore catheter.
Now you're trying, with the use of X-ray here, you're trying to find the exact spot. Is that what you're doing here?
So the purpose of the X-ray has a minimal role in this procedure, but it is useful in maneuvering and bending the catheter and directing it towards the mitral valve. So that's what we're doing here. And then Dr. Zuck shows us the valve and helps us orientate the clip towards the area of the problem, which is toward the right
See
side
that
of the
bright,
screen there.
see that bright shadow?
Mm-hmm.
So we are going to move the clip by way of those buttons and knobs outside the body and move it towards the lateral aspect of the valve, which is where the problem is. As you see, we're moving it to the right side of the screen.
Uh-huh.
And again, three-dimensional ultrasound imaging there is very useful.
So now we're looking from the top down through that valve, and you see on the far left the area of prolapse.
Mm-hmm.
And this is called the surgeon's view. This is pretty amazing that we can look at the valve as if the surgeon would look when the surgeon would open. The only difference is obviously we're not opening the heart.
Wow.
We're doing this from outside the body.
And this is rather new, isn't it, Dr. Goel, the ability to do this?
This was approved in the United States in 2013. So yes.
There it is.
And you've disconnected, this is a repeat, but that shows you disconnecting from the clip.
Right. We have grasped the leaflets. We're happy with the result. Dr. Zuck has shown us the leakage. And after we are 100% sure that we are in the right place and we've reduced the leakage, we let the clip go or release the clip.
Mm-hmm. There it was. Wow, that is, and now we can talk about another recent development, and I think you told me it goes by the name of Watchman.
That's right. That's another device which is relatively new. And Watchman device is a device which is basically sort of an umbrella-shaped device which we can place by similar technique inside the left upper chamber of the heart in a windsock-shaped pouch there called the appendage. And the purpose of the Watchman device is to reduce the risk of stroke in patients with atrial fibrillation or irregular heart rhythm who are not candidates for long-term blood thinners like Coumadin or warfarin or some of the other newer ones, most commonly by virtue of having significant GI bleeding or requiring blood transfusion or history of bleeding inside the brain. So the purpose is to place the umbrella or a plug in that windsock-shaped pouch to close it so that blood can enter that pouch or come out of it, and as a result, blood clots cannot exit that into the bloodstream, and that reduces the risk of stroke over long term.
Is there a local tie-in with the development of this?
That's a great question. Dr. Greg Mishkel actually is one of the pioneers in this technology. And
When I used to be a doctor.
when he was, in his peak time, when he was a flourishing interventional cardiologist,
Yeah.
he was leading the development of this program, and actually he's one of the authors on the first papers describing the Watchman technology.
So good of you to remember, Sachin.
You are our dean.
I do my
You are
homework.
Okay, you're the Dr. Goel. Thank you so much.
Thank you very much, Mark.
And Dr. Mishkel, you stay with us.
Okay.
We're going to be back in just a moment, and we're going to be talking with Dr. Goswami, so stay with us. Welcome back. We're going to stay with structural heart for just a few more minutes during the rest of this program. And one of the other procedures that falls into that category is called the TAVR, which is a transcatheter aortic valve replacement. Good. Okay, and you got to be surrounded by doctors to remember this stuff. But TAVR is a relatively recent procedure, and here at Prairie Heart Institute, they've been doing this for about 5 years, and they've just completed their 500th procedure. And that rate is picking up because they're finding out that more people are candidates for the procedure, and that the procedure has been really quite successful.
We're very fortunate. We have 2 alternative technologies that we work together as a team to offer patients. We heard about minimally invasive valve surgery, and then for other patients where that may not be applicable or alternatives want to be looked at, we can use transcatheter aortic valve. And as you said, the pace is picking up. The first year I think we did 49 TAVRs. This year we're on pace to 180 to 200. So every week there's 3, 4, 5, and some weeks, if it's very busy, six TAVRs.
Yeah, that's amazing. We introduced Dr. Nilesh Goswami now. He wears a lot of hats because we saw him in our last video that Dr. Goel was talking about. You were doing a MitraClip procedure at the time, but we wanted to ask you, because you're one of the 4 physicians at Prairie that does the TAVR procedure. The TAVR is the replacement of the aortic valve without having to break the heart, the bone.
Right.
You just go in through the veins.
Right. It's the complementary procedure to the mitral valve that we just saw. So it's a similar procedure to treat aortic valve disease, in particular aortic stenosis, without opening the chest as we traditionally have done. Instead, we just do it through the groin.
Wow. Let's take a look at the first clip, because this is the beginning of a procedure, and a lot of these transcatheter procedures start the same way, don't they, Doc?
Right. So really, a lot of the procedure is done before the procedure even starts, or before the day of the procedure, and that's a lot of pre-procedural planning. So they get a lot of imaging studies, a heart catheterization, a CT scan, and several echocardiograms, just to make sure there's no surprises or hitches in the procedure the day of. And so here they're prepping the device. We've already planned to put the device up through the leg, and once we get a large catheter up there, similar to what you showed with the MitraClip, we can put the valve in place.
A lot of people will be surprised to see this aortic valve. Those valves are bigger than most people would suspect that they, aren't they?
Yeah, they are.
Let's take a look at the next clip, because we'll show one here.
Your own aortic valve, typically the area of your valve is between 2 and 4 square centimeters. And a lot of these people that show up with aortic stenosis, their valve area drops to below 1 centimeter squared. And so it gets replaced with this valve that you're seeing here on the screen now. And so
Not the white plastic thing, but the thing in the bath,
And
in the white plastic cradle.
And they're going to take that out here and actually crimp it. They're going to make it, they're going to formulate it so it's going to roughly fit where they want it to go before they recrimp it again, I think. But
Right.
that's a large item. When you think that resting up in your heart, I don't think most of us really imagine that there's that much space for something like that up there. But what's he doing now?
he's starting the crimping process.
That's
So
the crimper.
Crimper.
That is the crimper. Essentially what this valve is it's a stent with valve leaflets sewn onto it. And these leaflets are sewn on there by hand. And it takes upwards of 12 to 15 hours for one person to sew that valve together.
Really?
Yeah.
Okay, now
1,200 stitches.
Why are they fitting it back into that glove-like thing? What are they going to do?
Well, that's almost a sleeve to protect the valve itself. And what they're doing now is loading it onto the balloon that will inflate it when it gets positioned in the proper place.
Okay, so that gets loaded onto a balloon. Now, you all have been using balloons and arteries for a long time, and this is just another way to expand something that's inside an artery. Is that right?
That's correct. So a lot of the stents we put in the heart and other places, other vessels in the body, we deploy a stent, and that stent most frequently is deployed with a balloon. So as the balloon expands, it expands the stent. Once the balloon's deflated, the stent is left expanded, and we remove the balloon from the middle of the stent.
Now, that crimping procedure, I can see now it fits on over the balloon, but that crimping procedure, that took a lot of measuring before you ever got to that point, didn't it?
It is. The valves come in different sizes, and obviously so do people. And so we have to pick the most appropriate size for that particular patient. If you pick too small a valve, the valve will leak. The new valve will leak, and you don't want that because that's been associated with poor outcomes clinically. And if you put too big a valve in, you can rupture the patient's heart, and obviously that wouldn't be good either. So we do a lot of pre-procedural planning to try to pick the ideal size before the day of the procedure.
Okay, now you've got it on the balloon. The next thing is, as we'll see in the next clip, the next thing is to actually get it into the vein, I guess, and into the position that you want it.
Right. We actually use the artery, the femoral artery, most often. In some situations, we can get the valve there through alternative methods, but most commonly we use the femoral artery, the artery in the groin, and come up backwards all the way through the belly into the chest and then across the diseased heart valve itself.
So everything is ready to go here, and they're about to take this long catheter with the valve on it over to the operators at the table. And there's everybody waiting patiently
waiting for the device. Where is it? Where is it?
There
well,
it
here
is.
it comes. And it's a handful.
Yeah.
So you can see our team there. There's Dr. Stevens way in the background, our cardiac surgeon. So this is a team sport.
Well, there are a lot of people in that room.
There are.
Well, again, we also have trainees who
Dr.
come.
Zuck is in there again.
There's
Yes.
Dr. Zuck. Good pickup.
By the end of the show, you're going to be able to do this, Mark.
Zuck on his own show one day. Hopefully next season.
Let's do that. He's really good at talking about it. He really enjoys that.
Oh, yes,
part of it.
he's a
teacher.
tremendously-
I think
yeah.
he's a born teacher. But now, what they're looking at the screen, though, is what I'm fascinated by here. What does that tell them?
Right, so that we have one catheter we put directly at the level of the valve, and then that gives us some reference as to where we need to land this. And so as we kind of come up and over into position here, that's what we're paying a lot of attention to is where is the valve sitting in reference to the patient's own valve. So we kind of want our new valve right in the middle, and then as we deploy it, it tends to shorten from one side versus the other, and so
the valve is coming around the bend, and sort of being lowered into position there.
And as much imaging as you have, the X-ray is still a very, very good tool. You need it, don't you?
yeah, it's crucial for this.
For this procedure.
The other interesting part about this is, so what happens here, if you were to think about blowing up a balloon in the outflow to the heart, so the heart's pumping, and if you blow up a balloon, the natural tendency for that balloon is to get ejected out of the heart because the heart's pumping forward. And so to kind of counteract that, what we do is we pace the heart at 180 or 200 beats a minute, and that reduces the outflow and output of the heart, so it tends to not spit the valve out, and the valve doesn't move while we're deploying.
Do you pace it with medication?
We pace it with a pacemaker. So one of the wires towards the bottom of the screen there is a pacemaker.
I see.
And so we just set that for 180. The heart is almost still, and so we can nail the position
It's
of the
pumping
valve.
so fast that it's pumping very little blood at any
Correct.
one time. Oh, that's remarkable. Okay, now, you got the balloon. It looks like the balloon is almost in place.
Right.
So let's take a look at what happens next, because now, are you using dye too?
A little bit of dye to make sure we're in the right place. We're rapid pacing, and then the balloon is now deploying the valve here. And we leave it up for several seconds, try to get full expansion of this valve so we minimize any leakage. And then we pull the balloon out, and the valve's in place and immediately starts to work.
Oh, it's already working.
It's working.
Okay, what do we see on the, see the ultrasound side?
So the ultrasound side now is used to assess whether there is any of this leaking that we spoke about earlier, because we know that if there's more than a moderate or medium amount of leakage, the patient doesn't do as well long term. And so to try to minimize that, we can do several different things. Probably the most common thing is just to expand the valve a little bit more. When you saw the valve initially, you saw a little rim of tissue around the stent itself, and that's a skirt that acts as a sealant to prevent these types of leaks.
Were you happy with what you saw on the leakage there with those color images?
Yes, yes.
So that looked like a good placement.
That was a good placement.
Okay, let's take a look at one more time now. With this is with the valve in place.
Right. And so towards the right of the screen, you see this loop wire that's almost in the shape of a circle. If there was a lot of leakage, you would see dye in that loop, and you really don't see any. So this was a very nice valve replacement.
And again, I think we noticed that this stent or this metal feature that was there, is that the valve that we're seeing, that metal, or was that there?
That's the
No,
frame.
That's
That's
the
the
frame.
frame.
You
and
can't see the
The
leaflets
valve leaflets are
Oh.
sewn onto
Okay.
that.
Okay.
onto the inside.
And so that valve that you just put in there replaces, you don't have to take the old valve out, it just replaces what was there.
Correct. We kind of push the old valve out of the way. You know, when a surgeon does it, he gets in there, opens up everything, cuts out the old one, and sews in a new one. We don't do that. So we just put the new valve inside the old one, expand it, that pushes the disease valve out of the way, and creates a nice new opening for the
Yeah.
blood to flow through.
Yeah. It's remarkable, you know, Dr. Mishkel, we've been doing this show on and off for some 15 years. And I thought, I didn't think I'd see that you could continue to make progress this way year after year after year, but now we see these examples of structural heart
Well,
improvements.
let me tell you
It's just remarkable.
real quickly, you know, and we'll have to do shows in the future, but we're planning new technology at Prairie Heart where we're going to be able to put in pacemakers and do atrial fibrillators without the use of any radiation, where it will be done with magnets and geo-positioning computer software. So more about that in a year or
Yeah,
so.
that'll be a relief to everybody, including the people that work in those rooms.
Right.
Well, I hope you learned something. I sure did. This has been Cardia, Hearts and Sciences, and the doctors of Prairie have been our guests, Dr. Goswami, Dr. Goel. Thank you very much for joining us. Dr. Mishkel, see you next time.